In this module, we'll be discussing how we approach surgery in high myopia. But before we start, we should try to understand the aspects of myopic traction maculopathy. So we generally take high myopia as greater than -6 diopters of refractive error, or an axial length of greater than 28 millimeters. Of these, 9% account for pathologic myopia, and up to 50% are associated with a posterior staphyloma. And these posterior staphylomas are some of the root causes for the problems that we see. Spade previously had defined a posterior staphyloma as an outpouching of the wall of the eye that has a radius of curvature that is less than the surrounding curvature of the wall of the eye. And you can see in this illustration by Professor Ono Matsui how the posterior staphyloma in image C shows the outpouching, and that posterior outpouching results in stresses on the retina. And this is one of the most characteristic markers of pathologic myopia and causing myopic traction maculopathy, as well as underlying chorioretinal atrophy. This may not be seen when the patient is young, but it does increase in prevalence and incidence with age and with axial length. And so in 8 to 34% of eyes with posterior staphylomas, we will find myopic traction maculopathy. This is both a clinical as well as an imaging type of diagnosis. Clinically, you will see these fine striae on the retinal surface radiating out from the fovea. And when you do an image on the OCT, you will see that the retina is spread out into an almost sponge-like appearance with vertical columns seen. And the underlying cause is really traction on the retina. On top of the retina, there's the contributing factors of an incomplete posterior vitreous detachment. Very often an epiretinal membrane is on the surface causing traction. And it's said that the small retinal vessels are very rigid and can provide tractional effects as well. Within the retina, the ILM is one of the biggest culprits. It's thick, stiff, and causes a lot of rigidity on the retinal surface. Underlying that, there's choroidal atrophy as well as RPE atrophy. The other contributing factor would be the posterior staphyloma. And when you put all these together, the retina is stretched in the anteroposterior manner, and the inelastic ILM then causes the retina to be pulled forwards and backwards. The retina cannot conform to the inner curvature of the globe, and there's progressive separation, but it's still connected by the columns of the Muller cells, which is quite nicely seen on OCT. Several groups have tried to classify myopic traction maculopathy. Shimada's group described this based on the extent of involvement, whether it's extrafoveal, foveal, and how much of the macula was involved from S0 all the way to S4. More recently, the Italian group have described this based on OCT findings of the inner and outer retinal changes that are contributed by both tangential traction as well as anteroposterior traction. And if epiretinal membranes are present, that's included as a plus. However, there is a very variable prognosis because the nature of the disease varies a lot from individual to individual, but it's generally accepted that this is a slowly progressive disease. There's a small chance of spontaneous resolution or improvement, and depending on what groups of patients are reported on, progression of disease is seen in 11 to 33%. And it's usually the more advanced stages like the S4s that progress towards foveal detachment, full thickness macular holes, which can then predispose the eye to macular detachments. In our own series of about 50 eyes of 38 individuals with an axial length mean of 29.8 millimeters, and spherical equivalence of -12.7 diopters, we found that over 1.5 years, 72% remained stable in terms of vision, and if the central retinal thickness did not change, vision remained the same, as you can see in these two examples. 14 eyes of this group, or about 28%, showed progression in terms of loss of 2 lines or more in vision, progression on optical coherence tomography, and of these, you can see that the majority were in the more advanced category of S4. 10 of these eyes underwent vitrectomy to try to resolve their pathology. We would recommend observation, especially of the more advanced stages, and consider early surgical intervention if there shows to be any signs of progression in terms of vision loss, progression of symptoms such as metamorphopsia, or on OCT there is development of foveal detachment or threat to macular hole formation. Myopic macular holes are not uncommon in high myopia, and it is a significant cause of visual loss. It is a result again of anteroposterior as well as tangential tractional forces on the macula, and is usually associated with an underlying progression of myopic traction maculopathy. In this example, you can see that this patient was followed up quite regularly and was stable initially with the S4 type of traction maculopathy, but over 15 months there was a progression with a foveal detachment and an outer retinal break. And so this patient then required surgery to prevent formation of full thickness macular hole and macular detachment. Macular hole detachments are very challenging surgeries to result in good surgical success when it's in a highly myopic eyes. Usually there's a deep staphyloma and the axial lengths are greater than 30 millimeters. While retinal attachment can be reachieved, the macular holes may not close in a large proportion of cases, and there's guarded visual prognosis even if there's closure because of underlying macular atrophy.